Hey, Diamond. Diamond, no. Diamond, you better freaking not. Diamond, I swear to God. She's looking at me. Diamond, put your ears down. No, stop it. She's growling just a little bit. Stop.
I can't hear it yet.
I know. I can barely hear it, but I know she's about to go off. She's fight. She's like, she was asleep. She's fight. Okay, heads back down. Heads back down. All right, we're in the clear.
All right, ready, set. All right.
Yeah, all right, let's do it.
Let's do this. Oh, man. Welcome to Tell Me About It, a podcast by SLPs for everybody. My name is Francie.
And my name is Maggie.
And today we are talking about autism part whatever. We talk about autism a lot on this channel, specifically when it comes to self-diagnosis. I feel like I've seen a lot online about like, here are symptoms of autism that are not necessarily in line or that align with the DSM criteria. So let's talk about it.
Yes. Yeah, this is kind of, I think we mentioned in one of our other episodes, this is kind of in our like hot button, quote unquote, series that we're doing, which is just where we're talking about things that we hear a lot of chatter on or chatter about online. And just like anything that gets really popular on the internet, there can be some good and bad that comes with that. So it's great that autism as a diagnosis is getting more visibility. However, we don't want it to go the way of like pop psychology, where it kind of loses its meaning or
like their diagnostic significance, right? Like I don't want it's a diagnosis. It comes with life experiences that are different than other people, and that holds meaning, and I don't want it to not hold meaning or become something that people are okay with dismissing because it's talked about so much, right?
Yes. Yeah, something else I want to note at the top here is that we will be referring to autism spectrum disorder, and we will be talking about deficits and disorder development that goes along with that, and kind of using those terms, which is something else that has kind of come up in this debate online. Should we as professionals be referring to autism as a disorder or as a difference? I fall into the camp of, yes, it is a disorder. That doesn't mean it's bad or wrong, but it does mean that there are parts of it that are certainly disabling and parts of it that, yes, are disordered, and if left without support, could lead to harm for that individual, even at low support levels. So that's kind of my perspective on it. Francie, do you want to, because you have a slightly different maybe take on it, and so
I think we're pretty well aligned. I think there's merits to the neurotype conversation. However, I think that if we lean too far into the neurotype conversation, we're going to miss opportunities for people to get the help they need to live lives as independent as possible by just saying, well, it's not really a disability, it's just a neurotype. When I know that I have worked with people, and you've worked with people who exist at that level 2 area, who definitely need supports, and with supports are able to be even more independent. And I don't want those resources taken away by people just dismissing it as not a disability, right? So I don't know. I live in both. I kind of walk between the two. I think there's merits to both. I think at level 1, we could have different conversations, but definitely at level 2 and level 3, we're having much different conversations about impact and support level. So that's where I'm at.
I would agree with that for sure. And something that I also, this is just a worry of mine that I am voicing. It's not necessarily something I think is happening, because it might sound kind of crazy, but I worry sometimes that the neurodiversity conversation, which I am a fan of and consider myself to be a neurodiversity affirming therapist, I think that conversation online can sometimes go the way of like people with different neurotypes are like almost like a different species of people. Like that's how it gets presented, when I don't think that that is true at all. Having a different neurotype, you're still a person. And so things that people need and things that work for people in general are also going to be true for people with different neurotypes. The like font or like the flavor might be different. And that's where we get into accommodations and supports and things. But yeah, I don't know. I think that sometimes autistic versus allistic, it becomes this like almost like you're talking about two different creatures or like beings, where it's like, no, like autistic people are still human beings. Like there's still things that work universally for humans. So I don't know, that is probably a tangent, but sometimes I see that online and I'm like, what are we talking about here? Like I feel like I lost the plot.
I think it's easy for these conversations online to become quite esoteric really fast, which once again, not inherently a bad thing, but I have to ground myself in the fact that these conversations impact people that I love and work with. And so those while this conversation gets quite esoteric, it's still important to me to know that at the end of the day, I have kids that I need to service, and what am I doing to better help their lives and their independence. And so I think, yeah, it's easy for people to be like, oh yeah, different neurotypes and things like that. But what is actually going to help my client? What is actually going to help my student to be successful? So ultimately, we still all have gray matter and white matter controlling our bodies and our lives. And so we all got brains, and though some of them work differently, largely we are still people. So
so we're going to talk about autism. We wanted to talk specifically about autism self-diagnosis. And this is to be even more granular with it. This is kind of in late teen to adulthood years. So we're speaking kind of specifically about people with what may be called level 1 autism today, or the diagnosis formerly known as Asperger's, from several years ago before that terminology was changed and is no longer used. Some people are still kind of familiar with it. I think that gives people who may be listening kind of a picture of what we are getting at here. So these are kind of your lower support individuals who sense that there is something different about their lived experience, something different in the way that their brain processes things, and are seeking out answers as to why, and may wind up self-diagnosing with autism or seeking out an autism evaluation as an adult. So we're kind of talking about that specific population. And Francie and I are both coming at this self-diagnosis conversation from two interesting perspectives of us. But we are both chronic illness girlies, if you don't know us personally.
Maggie and I have functioning bodies only some of the time.
I would say mine's a good 75% of the time.
Yeah.
We're working 75%.
I'm saying this as while driving home last night, slipped a rib for the second time in a couple weeks.
Oh my gosh.
Anyways, yeah, I'd say 75%. Yeah.
Yeah. Yeah. And so I have the experience of having diagnosed myself with a chronic disorder and being right. I was right. I am now formally diagnosed with that disorder. But so I'm coming at this conversation from like with the perspective of having been a person that has gone through this process, even though it's not with autism specifically, it's with something that ultimately does have a pretty large impact on my life, especially the past, I don't know, 5 years. It's really been, it's really been a part of it. So, but yeah, Francie, what about you? What is your experience?
Yeah, no, mine is a little bit of the opposite. I don't know how you feel about talking openly about your diagnoses, but I have Ehlers-Danlos syndrome and I have dysautonomia. And one of the things that was happening to me when I was in college is I started having pretty severe GI symptoms that were impacting my ability to function. Like I couldn't get out of bed. Like it was bad objectively. And it's pretty easy. I had gone down the rabbit hole of self-diagnosis and was like, I'm like so certain I have gastroparesis based off of what I'm experiencing and my other medical history. And when I went to the GI to explore this and talked about it, I got met with somebody being like, let's just explore a couple more options because there's definitely something going on, but it might not be that. And I'm glad we did that because it was not gastroparesis. I ended up getting diagnosed with some intestinal malformations that make me very prone to developing small intestinal bacterial overgrowth. Way more information than y'all need to know. But which presents similarly and has kind of a similar symptom set to gastroparesis, but with very different Very different etiologies and pathologies. And so,
And very
and
different
very different treatments,
Yeah.
very different treatments. And so, well, gastroparesis was a little bit more scary for me. I ended up with a much less significant diagnosis that is so much more easy to treat. And let me tell you, life could not be better for me having treated or having a consistent treatment plan for that. But I was wrong. Point blank, period. I was wrong. I was so convinced going into this. Granted, I was 19 at the time. Important to note.
Mhm.
I was so convinced that this is what was going on with me, and I was scared and not having a great quality of life. And I was wrong. And I got treatment accordingly, and now it's better.
Yeah. Yeah, and I don't mind sharing about my diagnosis at all. I talk very openly about it on my like personal social media pages and stuff, but I have endometriosis and it took me 9 years start to finish to get a diagnosis. It started just like many people with endo as soon as I started having periods when I was like 12 or 13. And yeah, I would just have horrible, horrible flare ups where I was throwing up, passing out. I would be down for the count for like 2 days of just like, I can't get out of bed. I'm in so much pain. Advil doesn't touch it. Tylenol doesn't touch it. Nothing really helped. And so as a teenager, I remember going in and telling my doctor, like, hey, is this normal? And the doctor was like, oh, yeah, some people just have bad periods. And I'm like, that's crazy because I feel like I'm dying once a month. And you're telling me that that's normal. So, and I know a lot of people have had similar experiences, but I was just rocking along, being kind of down for the count, few days out of every month for like 7 or 8 years. And then I finally got on birth control, which helped a lot with some of the symptoms. Hormonal birth control is like kind of the only way at this point, one of the few ways at this point that doctors have to treat endometriosis. And just like a big difference between me and Francie's kind of stories that we went through is, yes, I was right. I suspected endo the whole time. I ended up, that kind of the end of this story is that I ended up getting a care provider that believed me and said, no, that actually doesn't sound normal. That sounds like endo. Let's get you a diagnostic surgery. And so I did go through that surgery where they, lo and behold, found endometriosis. And now I have this diagnosis. But that didn't change my course of treatment. So what I was doing before is still what I'm doing now. But getting that formal diagnosis gave me so much validation and kind of like emotional and mental peace. There's a lot of like medical gaslighting, to use another term that's overused, but also actually happens. Like there's a lot of medical gaslighting that happens in women's health. So to actually have a formal diagnosis and say, no, I have this, I'm not making it up, I don't have a low pain tolerance, this is real, even though my treatment didn't actually change, that validation was really meaningful to me. So I think we kind of have these similar stories, but like we both got something different out of it. Where like you wound up getting the correct treatment and having your symptoms reduce and your quality of life going way up. And in my case, my treatment stayed largely the same. My quality of life is better now than it was before, but especially after the surgery. But the validation piece was really, really important for me. So that's kind of the perspectives that the both of us are taking into this conversation. We know what it's like to think that there's something wrong with you and to not have answers. And so, yeah, just a level of empathy, I suppose, that we're bringing into this conversation about autism. Do you want to start off by reading the current diagnostic criteria for autism?
Yes.
So we're all on the same page.
Yes, give me just a second. All right. Yeah, let's start with reading the diagnostic criteria. So the diagnostic criteria for autism spectrum disorder is kind of laid out for us by the DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. This is, I don't remember who makes this actually. Oh, the APA, duh.
Yeah.
The American Psychiatric Association. I knew the answer to that. Anyways, the American Psychiatric Association puts out diagnostic manuals. We're on the 5th edition. I don't know how often they do these. I've always had the 5th edition, I feel like. When did this
I
come out?
was
Did you start with
in
the DSM-4?
school, I think maybe I was in high school. I don't know. I remember when they were like, ooh, new DSM just dropped.
Yeah, right? Yeah, that would have worked out because it was 2013. So yeah, high school.
Yeah, I was in high school.
Anyways, so long as we've been in our professional careers, we've had the DSM-5.
Mhm.
And so with that, they've got the standards for what it means to be diagnosed with autism. And so according to the DSM-5, a child must have a persistent deficit in each of the 3 areas of social communication and interactions, plus at least 2 of the 4 types of restrictive and repetitive behaviors. And there's all of these different little subtext boxes that we're getting ready to talk about in response to those. So let's see here. It must have persistent deficits in each of the 3 areas, A1 through A3. So A1, a persistent deficit in social communication and social interaction across multiple contexts as manifested by the following currently or by history. Deficits in social emotional reciprocity, ranging from, for example, from abnormal social approach to failure of normal back and forth conversation to reduced sharing of interest, emotions, or affect to failure to initiate and respond to social interactions. Deficits in nonverbal communication behaviors used for social interaction, ranging from, for example, from poorly integrated verbal and nonverbal communication to abnormalities in eye contact and body language, or deficits in understanding and use of gestures to total lack of facial expressions in nonverbal communication. Deficits, and this is A3, subpoint 3, deficits in developing, maintaining, and understanding relationships, ranging, for example, from difficulties adjusting behavior to suit various social contexts, to difficulties in sharing imaginative play or in making friends, to absence or interest in peers. So your social communication has to be impacted to a level that is clinically significant as outlined by A1, A2, and A3. So you must have persistent deficits in all of the 3 areas that I just mentioned.
Yeah. And so again, just kind of the like catchphrase for each one would be reciprocity. So this is kind of like back and forth conversation. It also has something to do with like knowing the appropriate amount of information to share. So not too much or too little. Nonverbal communicative behaviors, gestures, eye contact, body language, etc. And then developing, maintaining, and understanding relationships, friendships, various social context, the fact that you talk to your boss differently than the way you talk to your friend, and that kind of thing. So, and then these are rated on they're rated on a severity scale of 1 to 3. 1 means requires support. Level 2 is requires substantial support, and level 3 is requires very substantial support. So yeah, and something I think that's important to point out for all of this is the persistence part. So this isn't just like for the first few months of being at a new school or, you know, the first couple of months after someone passes away and dealing with the grief of that there may be changes in social communication. It is persistent and also across the lifespan. So not something that just pops up in adolescence. This would also have to be present basically from birth or very early development.
Yes, it's actually on the website. I'm using the CDC, which is referencing the APA in their breakdown. And one of the notes, it says after listing Group A and Group B of the diagnostic criteria, Group C is symptoms must be present in the early developmental period, but may not become fully manifest until social demands exceed limit of capacities or may be masked by learning strategies in later life. So,
and I think that this is really important for kind of the specific group of people that we're talking about today. So like you and I both work with kids, and we worked with very young kids where after a while we're like, I think this kid's on the spectrum. But it has not reached a point where they're not able to like access their environment yet because they're in kindergarten or first grade, where there's not a ton of social expectations placed on kids. So if they are a person that just requires a little bit of support, and that's going to be kind of their diagnosis, hypothetically, they may kind of fly under the radar for a while. So that's kind of the skinny on social communication. RRBs, or
Next.
restricted and repetitive patterns of behaviors, interests, or activities, are next.
Yes. In this list, two of the following examples must be present either currently or by history. So stereotyped or repetitive motor movements, uses of object or speech. To me, this kind of reads as stimming, if I'm being so for real right now.
It's stimming, but there are stims, types of stimming that are stereotypical of autism.
Yes.
So
I think of one in particular. If like a kiddo really loves like the wheels of cars and will sit and spin a wheel in front of their face
spinning, yeah,
for like hours and hours and hours.
Lining up toys is another big one for kids.
Finger flicking,
hand flicking. They are very common in the autistic population. It doesn't mean that every child that does these things. So again, diagnostically, you need 2 of the following lists. So if a kid loves to line up their toys and they don't have any other diagnostic criteria,
you just have a kid who loves lining up toys.
Just love to line things up. And you know what? Let them.
Good for them.
I think that's great.
Good for them.
But yeah, there's lots of things. Echolalia is another one that kids, it is developmentally appropriate for a certain age range. I'm blanking on what that is. It's young though, early childhood. Echolalia is another one that like, yeah, a kid might do this and they may not be autistic, but it is very common in the autistic population.
The next restrictive and repetitive pattern would be insistence on sameness, inflexible adherence to routines or ritualized patterns of verbal or nonverbal behavior, with something like extreme distress at small changes in patterns, difficulties with transitions, rigid thinking, greeting rituals, need to have the same routine or same day or same foods kind of situation. So that kind of, that ritual, repetitive, and need for sameness. Yeah.
A question that I ask parents, it is an autism screening question, which I'm not evaluating autism on my own. But it's something that if I'm doing intake with a new client, I would just want to be on my radar. I will ask, like, does your child have a highly preferred item or object that they carry around with them? And sometimes they're like, oh yeah, they love their like Lightning McQueen car. We have a Lightning McQueen car at home. They love it. They take it in their backpack to school. It's like their comfort item. They're never without it. I'm like, okay, what happens if you can't find it? Or what happens if like we have to put that down so you can go eat lunch? Or like, and that their response to that question gives me as a clinician some information of like, if we have a meltdown that derails the rest of the day, if Lightning McQueen is lost or missing, then that's a little outside of the range of what I would consider neurotypical. If they're like, they are upset when we can't find it, I have a backup on hand, I'm like, that's a little more, especially for a toddler, like sometimes they get really, really attached to things. But if they're like, oh, they love it, they bring it with them everywhere, but they also really like to play with their little people garage set or whatever, then I'm like, okay, so we have kind of interests out expanding. Again, it's kind of a screening. It's just something that would put a little data point on my info about this child. But yeah, RRBs can also be other things. It can be special interests. It can be diet and feeding.
Yep. The next actual dot is highly restricted fixated interests. So kind of going what you were saying with special interests.
Oh, okay.
That are abnormal in intensity or focus. So strong attachment or preoccupation with kind of things that are outside of the norm or excessively circumscribed or perseverative interests. So they're just really, 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 really stuck on it.
Honestly, I kind of love it if I have an autistic client that has a really specific special interest.
Please, I love it.
It makes it easy for me to plan therapy. And I know that they're having fun because this is their special interest.
This is what they want to talk about.
Want to do.
Anyways, this is a special interest that is beyond just like an interest or passion like topic.
Mm-hmm.
It is impacting potentially like your ability to go about your daily living kind of situation, because that is all we're thinking about.
Yes.
So
yeah, or like it impacts your ability to form relationships with other people, because if all you talk about is one topic, that is really hard. It's hard to form relationships or have a conversation with people you don't know very well if you are kind of unable to move past that topic. Something that I think a way that this can get masked is I've heard people postulate online that girls with autism tend to have more socially acceptable special interests or like restricted.
Absolutely.
So like they may be really into Barbie and know absolutely everything about Barbie, talk about Barbie all the time, everything is Barbie, but little girls are supposed to like Barbie, supposed to, you know, quote unquote. Little girls can like whatever they want, but like that's a normal thing for little girls to like. So people don't really pick up on it as a special interest or restricted interest because it falls within the kind of expected gender expectations for that child. So yeah, I was mistaken earlier saying that the insistence on sameness would be a special interest, because I think those are actually separated out.
Two separate things. The last one is hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. Apparent indifference to pain, temperature, adverse responses to specific sounds, textures, smells, so on, visual fascination with light or movement. And I feel like this is the one I see talked about online the most, if that makes sense.
Oh, really?
I feel like people are talking about stimming, and I feel like that's where that sensory input comes in the most. People are talking about stimming online the most, because you can have sensory differences in the absence of autism. And so, I don't know, I feel like this is the one I see people talking about where they're like, oh yeah, well, I just like really like hate the texture of microfiber cloths. Which, like, fair and valid. They do get really catchy, but like you have to look at that feature in the whole diagnostic picture when it comes to diagnosis of autism, if that makes sense. This is one big mosaic, I guess is what I'm getting at when it comes to diagnosis and self-diagnosis. So
yeah, this is again another like there are kind of things that would be maybe typical or expected versus stuff that's maybe more indicative of autism. So like you and I, Francie, have both had students that we work with that one kid in particular I'm thinking of would go over to the air register in the classrooms and stand in front of it and let the continuous airflow blow in their face and hand flap and stim in front of it. And that was really, they loved it.
Regulating.
They loved to just go over there and do that. That was really fun for them. As someone who has an adverse reaction to like wind in my face, I was like, I don't get it, but rock on, little man. Like
good for you.
Love that. I don't get it though. But yeah, so that is something that would kind of fall outside of the realm of like, oh yeah, there are things that are like polarizing. So like microfiber cloth is one that's like, I feel like that's a really polarizing texture. People either
cotton balls. I feel like the cotton balls is another one that I see.
Like people either like don't think about it at all, or they hate it, can't stand it.
Yes.
Yeah. And I feel like there's lots of things that are kind of like that. Tags in clothing, maybe another like more common one. Seams of clothing. I know you are a big seams girly.
Yeah, I'm a seams girly. I still buy socks without seams because it just doesn't sit right with me.
Just bugs you.
But it's just not for me. It's just not for me. But that does not necessarily mean I have the other features, but I just have sensory preferences, you know? Same thing with foods. I don't like tomatoes because their texture is just not for me kind of situation.
Textures in food would be a big one too. Getting stuff on your hands. I've worked with a lot of kids that
I am the person who, when cooking, will turn the sink on and like do the little
No, me too. So
yep.
I don't like to have stuff on my hands, and like if you ever share a meal with me, I will be like constantly wiping my fingers in my mouth. I don't like to have food residue at all. But I've worked with autistic kids who cannot tolerate anything on their hands, and that like to the point where like it's crying, they're very distressed, like we're trying to get it off of their hand as fast as possible.
And that's making them more mad.
And like, that's making it worse, because then it's more stimulation on the hand, and it's just, that's a tough situation. So that would be kind of the level that we're talking about here. Yeah. All right. The third, we already kind of talked about the third column here, which is symptoms must be present in early development. And are lifelong. So would you be okay with skipping down to D?
Yeah, absolutely.
Okay. So, and this is a really kind of gets to the heart of why we're talking about this, I think. This fourth kind of pillar of diagnosis for autism is that the symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. Do you want to talk about what might constitute a clinical impairment?
Yeah. So it is impacting your kind of daily function. I am going to use an example. So take, for example, you have somebody who is interested in hunting, which seems like a very normal interest. However, maybe
especially where we live.
Specifically where we live. However, if that interest has you missing work without calling in because you're so fixated on whatever it is that you are hunting that season, and not just kind of like a, hey, I'm calling out for deer season, but like a no call, no show, I'm in the woods and I didn't think about calling anybody else. It's impacting your, your function at your job, right? Or like you can't get through your day without needing some type of sensory input. Like I'm thinking about some of my kiddos who have pretty significant sensory needs, who maybe need some type of accommodation to even just get through the school day, right? And so it's impacting their daily living for, maybe they're distressed throughout the day because they need that sensory input. So anyways, it's negatively impacting their quality of life, right?
Something I might put in this category too with those like occupations is someone who might have really significantly different sensory needs, who for that reason can't stand showering, grooming, bathing, brushing teeth, and like can't stand or tolerate the feeling of being wet for very long, which is
entirely valid.
Need.
Yeah.
We don't get to pick what drives us crazy sensorily. I have a borderline phobia of the sun because of my like sensory needs with it, which is why I look like this. We don't get to pick that, right? So it's valid, but that has other adverse health effects. If you don't bathe, if you're not grooming yourself properly, you can actually get skin infection. You can get cavities in your teeth if you're not brushing your teeth often enough. You can, there are things that, you can get sick. And it can also, unfortunately, impact kind of social things or other like aspects of job, work, school. So that would be an example, I think, of it clinically. One of these pillars of the diagnosis, like being clinically significant.
Yeah. And so if you like, great example is Maggie's sensory differences. She hates the sun, but she can still pop on some sunglasses and a sun hat and work fun and field day because I've watched her do it, right?
Yeah, I did have to like really accommodate and support.
You did.
Which that's the other thing is like, I know that this is a subclinical level of distaste for the sun, because when I have my polarized sunglasses and my hat, I am A-okay. I'm ready to go. My sunscreen.
And your parasol.
Yeah, I do carry around an umbrella if I'm going to be out in the sun for.
But that doesn't stop you from being able to go to the grocery store. It doesn't stop you from, like you can accommodate and work with it. But for some of the kids that I know you and I worked with, it's like non-negotiable. Like it's not something that we can just accommodate for and move on. Like it's needs that we have to find a way to meet, and it impacts our ability to go about our day, right?
Yeah. Or like the example of hating the feeling of seams or like something in your clothing. Yeah. You and I have both worked with students that if they suddenly kind of become aware of like the feeling of their clothing, they will take it off. Like they will truly take their clothes off.
Or like if a kid gets something wet on their shirt and it's
take
like
it off.
Gone now. Yeah.
And that is like kind of tied to this sensory need of like cannot tolerate the feeling of being wet, cannot tolerate the feeling of like tags, seams, etc.
Mm-hmm.
But we can't be naked in public. It's not safe. If you're old enough, it is a crime. We need to make sure that like, clothes stay on. So
Mm-hmm.
that's something that needs to be supported and is kind of clinically significant.
I think the next part, not just with the clinical significance, but kind of part E is the part that I think you and I wanted to focus on the most
Mm-hmm.
because interestingly, autism, I feel like I've heard you use these words before. It's like it's a diagnosis of exclusion, right? You have to go through, is there a better explanation for why these things are happening other than autism before we diagnose with autism, right? Like it is.
That's how I go about it, and that's how I frame it, because autism is a lifelong diagnosis. It's not something that goes away. If you have a formal diagnosis of autism, that stays with you for better or for worse, right? I think that's good on the one hand because it can help people get the supports and services that they actually need. But that's really tricky if we wind up with it being like a misdiagnosis, right?
Mm-hmm.
So that's why differential diagnosis is really important. And I do treat autism as a diagnosis of exclusion. Like this column E it's basically like these disturbances or clinical significance are not better explained by something else. So, yeah.
And I think this is something that you and I have talked about in private before, is there's a lot of things that can look like autism and not be autism.
Yes. Yeah. The CDC website does list a few of them. Intellectual disability is one, global developmental delay, which is kind of an annoying diagnosis because it is so broad.
So broad. It's so broad, yeah.
But intellectual disability, global developmental delay, some other. So, and I want to be careful here because I think that some of these other diagnoses that are kind of coming to mind for me may look like autism to kind of the untrained eye. So someone who isn't aware of all four of these columns and isn't kind of going through them and thinking critically about each piece. So something like having, significant trauma in early childhood could produce some traits that look like autism.
And we're specifically speaking to level 1 autism. I feel like there's a lot of things that can look like level 1 autism. CPTSD can look complex, complex post-traumatic stress disorder can have a lot of overlap with symptoms that are kind of described as autism.
It can cause that need for sameness and security. It could even cause like really intense adverse reactions to sensory input. But it is not autism, right? Because we can point to a cause of it.
Mm-hmm.
Yeah.
Other comorbid mental health things, anxiety and OCD can sometimes overlap with diagnostics for autism, right? Even though, once again, sometimes they can be comorbid, sometimes they're separate diagnosis, but sometimes they look very similar. And so all things to consider when going down this like path of diagnosis is all things, you got to look at as a whole person, specifically if you're doing this later in life. I feel like because of the mental health components of it, if that makes sense. So
yeah, OCD I think is a big one because of those. And in OCD, they're not restricted in repetitive behaviors, it's compulsions, right? And you go about treating those differently. And they may have, like, RRBs and compulsions can both have significant impacts on a person's ability to like go about their daily life. But the way that you would kind of learn to manage those is very different. So that's why it's important to have this differential diagnosis. But yeah, we talked about, I'm trying to keep like a running tally of ones that we've like touched on. So intellectual disability, global developmental delay, which again, it's kind of a helpful diagnosis, but we talked about trauma and PTSD. We talked about OCD, ADHD. I think we are also seeing some bleed online of autism and ADHD are kind of becoming the
They're
same condition.
morphing. They
They're
can be
morphing.
comorbid. Yeah, they're morphing. I feel like they can be comorbid, which means that they can occur at the same time and are sometimes diagnosed together. But they
Yeah,
are very different things. Very
very.
different things.
Yeah. So, like someone who may have that kind of hyperactivity that is indicative of a person with ADHD and maybe has a um I'm trying to think of what I'm trying to get at here is the like kind of executive functioning piece of ADHD that may look like an autistic need for
Yeah.
structure and order or something, etc., like that.
I'm thinking of it when it comes to social and pragmatic language. Sometimes our executive functioning skills are, if you have ADHD, you've got an executive functioning disorder, and sometimes that executive functioning disorder leads to us misreading social situations, and sometimes that can look like that social language component of an autism diagnosis, right? Even though they are different, or
Way
sometimes
better.
that like
Yes.
EF, or I think about it. So once again, I'm coming from the brain of I work with kids who are oftentimes already diagnosed, and one of the big characteristics, as we just talked about, is language and co-occurring language disorders. And sometimes ADHD and our part of the executive functioning disorder side of things can look like a language disorder because our brains aren't organized enough to go back and access those language stores. And so that can even make it look even more like autism sometimes. So,
Totally. Yes. And then there's also just kind of a phrase that you and I use a lot is like subclinical levels of quirky. Like there are a lot of these symptoms that kids may display in isolation. There, like we said before, there may be a kid that is doing a lot of the kind of stereotypical autistic stimming, hand flapping, finger flicking, that kind of deal, but that's it. That they're not, are their social communication is within normal limits, their sensory needs are within normal limits, but they love to walk on their toes and flap their hands. That is kind of like a subclinical, like, all right, this is not clinically significant. It's just different. They're just kind of doing that. And how much is that really impacting their daily life?
yeah.
All that being said,
Mm-hmm.
and you and I have both shared kind of our perspectives on self-diagnosis. I think like looping it kind of back to being like, is this impacting your daily life to the point where you want to put some supports in place? Or is this impacting your daily life? Or did it used to impact your daily life before you got really good at masking to the point where like this would be so emotionally validating to know what is happening? Because I think those two are very valid reasons for seeking self-diagnosis. And yeah. Does that make sense?
It's seeking self-diagnosis and official diagnosis. I think you put that better than I think I ever could have. And so
I just kind of rambled through that and I kept going back and forth between like, okay, is this me outlining right now where we're brainstorming or is this me actually saying it for
that was first take. She did it great.
Got it in one. Yeah. I'm sorry.
No, I think
Yeah.
that, yeah. No, I think you did that great. Yeah, all this said, while there are these are the specific diagnostic criteria that we've talked about, and it's entirely valid to self-diagnose and want answers. And if you have questions or or your life is being impacted, self-diagnosis is valid. We understand that medical care is kind of a luxury these days. It shouldn't be, but that's where we are.
Oh.
Um, and yeah, get the answers you need. That's what I say.
I also agree. I think that um, I would just caution people against kind of irresponsible use of this information where like
Yeah.
I don't want autism to become a pop psychology thing. I don't want it to become this thing that where the diagnosis gets harder to receive for people who really need support because it is kind of so widely I don't know, given, talked about, etc.
It's just kind of it's just in the sphere of people's consciousness right now. And I think more people getting diagnosed I think people are getting diagnosed more, which is a good thing. But I just don't want it to get so talked about that people lose what it actually means, if that makes sense, or not
Yeah.
necessarily. Or I just want people who need their help to get the help that they need. That's what it comes down to. I just want people who need help to get help. So, or
And
if
like
you need
I've
support,
been
get
in,
support.
yeah, I have been in conversations like with real people where they're like, well, everybody's a little bit autistic. And it's like, no,
No.
no. Autism is a different neurotype. Like this is not, it's not everybody's a little autistic.
Yeah,
Just
and it's
because
and
I
it's more
have,
than just being a little quirky, right? Like I think that's why I kind of teeter on going back to what we were talking about at the beginning. I think this is why we kind of teeter on that neurotype conversation because sometimes it can be really impactful in somebody's lives and they need support in order to function and I don't want them to never get that support if that makes sense. So, that's where I'm at.
and conversely, sometimes like in my case, I got so much validation and so
Yeah.
much emotional impact out of getting my diagnosis after 9 years of being like, this is not normal. I am in pain. Um, but at the end of the day, my treatment didn't change. So, like, I could have, in theory, continued on without ever knowing. And so,
Mhm.
like, it is kind of a personal decision at that point of like, well, is this going to change anything about my life? Is this going to change the way that I know myself? Is this going to change the way that I interact with other people? Are there even supports that I need at this point that
Yeah.
that I'm unable to access without a diagnosis? So I think it's really important to go through those considerations too, just because you're right. Like, unfortunately, healthcare is not easily accessible for a lot of people. And so like it's a factor that needs to be taken into consideration when you're making a decision of whether to like seek out a formal diagnosis or potentially self-diagnose and kind of have this working, like, I'm pretty sure I'm on the spectrum. Here's why I think that, like, because that is valid.
Mhm. Entirely
I feel like
valid.
I kind of lost my point in there somewhere, but
No, I tracked it. You're good.
okay, good. I think there was one more thing I wanted to say about this. Oh, this is what it was. Okay. I have seen this online. Um, Adults who highly suspect that they have autism go and get a formal diagnosis, and the diagnosis is you do not have autism.
Yeah.
So that I think, and Francie, you may be able to speak into this a little bit more. Um, that I think can be really upsetting. And I have seen people online even go so far as to say, like, well, I still think I have it, so I'm still self-diagnosed. I would really caution against
And
doing that.
that's kind of the unfortunate part of self-diagnosis. And I speak both from, I don't know, I have a complicated relationship, much like I have my own complicated relationship with my health.
Yeah.
Insofar that like if you are seeking that emotional validation, sometimes it can be really crushing when you're wrong.
Mhm.
I mean, it can be really crushing. And for me, while I had really set my sight on like, oh crap, like this is probably what's happening to me because this happens to a lot of other people with Ehlers-Danlos syndrome, uh, it was the best possible scenario for me outcome wise. And so I feel fortunate that I didn't go through that heartbreak stuff, but it was a big mindset shift. And so it was kind of a shock to my system to be like, oh, that I'm overwhelmingly relieved because I did get an answer. It wasn't the answer I was anticipating, but it was the answer that I needed. But if you're going for that kind of more in Maggie's line where like I needed the answer for my emotional health,
Yeah,
it can be really upsetting to your apple cart if you've kind of gone
absolutely.
all eggs in one basket and now that you went for a formal diagnosis now you don't have that can be really upsetting,
Yeah.
you know.
I
And
was
so
in tears the night before my surgery because I
yeah.
thought they weren't going to find endo and I didn't know what to do. Like, I was so scared that they weren't going to find it. That, like,
Yeah.
and
I see that same conversation a lot, specifically in people with Ehlers-Danlos syndrome, where they can suspect for a long time and then they go for formal diagnosis and they don't get it, and that's really upsetting because they are still having struggles, right? Like they sought out formal diagnosis because it was impacting their daily living, right? And I feel like that can be same for people who are in their adult life seeking an autism diagnosis. Something is happening that is causing you to seek that out, right? Whether that's the emotional reason or you are having impacts. And so it can be such an emotionally taxing and full of emotional turmoil time to do that when you find out that that's not what you have.
yeah,
And so in my case, it worked out because I got an answer that I needed And I got treatment that I needed. And so that would be my recommendation, is if you do go down this path and you as an adult in your adult life are seeking out that diagnosis and you end up with something different, maybe you have a condition that presents similarly and you can get the treatment for that condition, because let me tell you, my life is so much better.
Yeah, I was
But
gonna say, like, kind of the risk that you run with this is like taking the examples of like OCD and autism.
yeah.
If you believe that you have autism and you're kind of fall into this self-diagnosed category, but then you go to get a formal diagnosis, they say, no, it's not autism. If you continue to seek, if you have the luxury again to continue to seek, and you find out that it's OCD, those are two
There's
different
treatments.
courses of
Yeah.
treatments. And so it's really important kind of in cases like that. Same thing with trauma. If you have complex post-traumatic stress disorder or post-traumatic stress disorder, that the treatment for that is vastly different. Like the supports for that disorder versus autism are different. And so if you're kind of going down this trail of autism and it isn't, you may be missing out on treatment that could be just that more effective and increase your quality of life even that much more. Even though it really hurts to not get answers.
It sucks. And I
It
want to
really
go on the record saying, I know that feeling too, right? Like I've gone through the whole misdiagnosis thing, not just with this situation, but like when I was initially getting diagnosed with EDS, and knowing that like, because fun fact, Maggie, I think I've told you this. I was actually diagnosed with rheumatoid arthritis beforehand, but I never had a positive blood
did
test.
tell me that. Yeah.
Because it was the 90s and 2000s and nobody knew what EDS was. Yeah. And so anyways, that was a surprise to my system too, where they were like, actually, you don't have this thing you've had your whole life. It's actually this other thing. That was crazy, but I digress. All this to say, I know how it feels to be like, I thought this was happening with me, or like I really thought this was what was going to help me get footing and define my life, and define my experiences, and that's actually not what's happening. And it's always worked out for the better in my case. So let that be some survivorship bias right there. So
yeah, so I love some survivorship bias. Yeah, again, like the scenarios aren't exactly the same, but like I know the fear of thinking that I'm again going to say something's wrong with me, I'm in pain, and again have a medical professional say, no, you're not, you're normal. Like that is really scary, because then you're left with nothing, you know? And so it is, yeah, it's tough, but well, yeah, it's just tough.
It's just tough out there.
It's just tough.
It's tough out there.
Yeah. So that is kind of a brief dive into the realm of autism self-diagnosis. We think this is an important topic to talk about as autism becomes more and more popular and kind of takes on more and more of a spotlight. I think that if you are self-diagnosed autistic and you're listening to this and you have found like the same emotional validation that I found in my diagnosis, like I think that there's value to that. That's valid, you know? But I mean, if you're someone that's still kind of seeking and looking for answers, again, I would just caution against thinking autism automatically, because there could be something else that's going on that may have different treatment or different supports to put in place. So
that's what we got.
Fun, complex topic.
Yeah, this is a broad, brief overview for a really kind of complex topic. I feel like I say this a lot on our podcast, which I'm pretty sure people get PhDs in this. So like we're just two ladies just gabbing about this. So this is complex. This is tough. So anyways, we welcome conversation about it. So
having been on a diagnostic team for autism, like these conversations also happen between care teams of saying like, well, we observed this behavior during XYZ test. Okay, but they have this in their history. Could this be better explained by, blah, blah, blah. So I think good diagnostics for autism happen on a team, and good diagnostic teams have differential discussions like this. So yeah. Anyway.
that was tell me about it.
Hopefully that cleared some things up for you guys. I don't know if it cleared anything up for us. I feel...
We're constantly in the weeds. That's all
I
I
know,
got.
constantly in the weeds. We're trying. I may be in the weeds, but this is my garden. All right.
Uh,
I live
oh,
here.
put that on a cross stitch. What?
Um, so yeah, this has been Tell Me About It. We are available on Spotify and YouTube at Tell Me About It, an SLP podcast. And we are also available on Instagram at Tell Me About It SLP. We will see you next time. Goodbye.
Bye.